Welcome, everyone, to the 8th Annual Focus on Fellows. This is our second program we have hosted this month. Thank you to those that attended our program on June 4th. My name is Dr. Bhargavi Patham. I'll be your MC along with Dr. Robert Eckel, who needs no introduction. I am an assistant professor of clinical medicine at the Weill Cornell Medical College, and I practice at Houston Methodist Hospital. I'm a member of ADA's Focus on Fellows Advisory Board. None of this would be possible without the guidance of ADA's Early Career Advisory Group. We would like to thank the members for all their hard work to develop today's program. We are also very grateful for the support of the Leona M. and Harry B. Helmsley Charitable Trust, who have made this meeting a possibility. A few items to go over before we start today's program is to remind you that ADA's 81st scientific sessions will take place virtually June 25th through 29th. As a Focus on Fellow participants, you will receive complimentary registration to ADA's 81st Scientific Session virtual meeting. Following the June programs, you will be receiving instructions on how to register for free. As Focus on Fellow participants, you will also become a member of American Diabetes Association. This is a free membership and will provide even more opportunities to network and grow professionally. ADA memberships include a variety of professional members benefits, including meeting discounts, Women's Interprofessional Network, WIN-ADA, interest groups, Diabetes Pro Member Forum, professional journals, members-only webinars, member directory, standards of medical care in diabetes, and Diabetes Pro Quarterly. As you can see, you will have access to lots of great resources as ADA professional member. You will receive information about membership following today's session. We will spend today's program by following the agenda on the screen. Please note that today's presentations and workshop will include Q&A. If you have questions as we move through these presentations, please type them in the Q&A box in your control panel. If you would like to ask a question live, you can let us know in the chat, or you can press the raise hand button, which is located in the reactions tool on your dashboard. It could also be listed under more or options. We will be answering as many questions as we can through each session. I now have the privilege of introducing Dr. Cynthia Munoz, President, Healthcare and Education for the American Diabetes Association. I think she does not need any introduction, but Dr. Munoz is a bilingual licensed psychologist who holds an appointment as Assistant Professor of Clinical Pediatrics at USC Keck School of Medicine. Currently, she provides clinical care to children and youth with diabetes in both English and Spanish at Children's Hospital, Los Angeles, Division of Endocrinology, Diabetes, and Metabolism. Thank you, Dr. Munoz, for joining us today. I'll now turn it over to you.
Thank you so much. So it's morning here, so good morning or good afternoon, wherever you are. Thank you for participating in this really important program. And what a fantastic perk to have the opportunity to participate in the 81st Scientific Sessions. So I'm joining you today from sunny Los Angeles, where I am, as was mentioned, faculty with the USC Keck School of Medicine. I practice at Children's Hospital Los Angeles. So I'm a pediatric psychologist who specializes in the care of children with endocrine conditions, primarily diabetes. In pediatrics, we know that the rates of type 1 and type 2 diabetes continue to rise for children, with a disproportionate impact on children of color. Similar to adults, we also know that children and youth with diabetes are at increased risk for mental health challenges, including depression. The pandemic has had a deep impact on the lives of people with diabetes. For example, there has been a reported increase in the rate of DKA for patients with new onset type 1 and type 2 diabetes in pediatrics during the pandemic. People who experience DKA diagnosis are at risk for poor outcomes, so this is understandably of great concern. Timely diagnosis and symptom management have also been more difficult during the pandemic because families stopped going to well visits and to the emergency department out of fears of exposure. There were also reduced opportunities for physical activity, school based health support, as well as access to diabetes supplies and food. Children and teens also reported significantly lower health related quality of life and more mental health problems than before the pandemic. And this impact has been greater for children with low socioeconomic status and migration backgrounds. Researchers reported that people with diabetes who experienced higher levels of worry about COVID 19 could be more vulnerable for diabetes distress, hyperglycemia, depression, anxiety, and so much more. As a mental health professional in the field of diabetes, I work closely with our entire team, our physicians, including our fellows, our nurse practitioners, dietitians, social workers, occupational therapists, physical therapists. Working collaboratively is vital. After all, while we strive to provide whole person care, we cannot do it all, and teamwork is key. Resources are also key. And this is where the American Diabetes has been a vital part of my team's ability to provide optimal whole person care. So I encourage you to continue your involvement with the American Diabetes Association and use the numerous resources available to you and your patients, including, of course, the standards of care, which are available online and through an app, as well as the paper form. We also have a diabetes mental health education program for mental health and behavioral health professionals on your teams who would benefit from learning about the care of people with diabetes. We have the mental health provider directory. This is an online searchable directory that you and your patients can access to find mental health providers with working knowledge about diabetes. Information about legal protections is also available through the American Diabetes Association. This includes information about students' rights through Safe at School, and these are students at all levels, not just elementary, middle, and high school, but also college students and beyond, and graduate students as well. So you'll appreciate taking a peek at what the accommodations are for these students and the protections that they have. This is a helpful resource for students, again, of all ages. There's also information about the rights for people with diabetes in the workplace, including commercial airline pilots, commercial truck drivers, and resources to help people access insulin and specific resources to ensure access to life-saving medication and supplies in the event of a disaster through the ADA's involvement with the Diabetes Disaster Relief Coalition. All of this information is available at your fingertips online. You'll also hear about some of this work during the scientific sessions. As you build on your professional career, take advantage of opportunities to join the ADA's interest groups, local and national committees, advocacy efforts, and opportunities to present your research and clinical work at the scientific sessions. By becoming involved with the American Diabetes Association, I know I've had the opportunity to directly interact and collaborate with eminent people like Dr. Eckel in the field of diabetes. And I can guarantee that I would not have met these individuals were it not for my involvement with the ADA. There is one more thing I'd like to say. Please take care of yourselves. Diabetes and caring for people with diabetes is not easy. It is relentless, and as a professional caring for people with diabetes, you may feel some of the impact of this chronic, relentless condition, and you may feel like you are saying the same things over and over again. Self-care is critical to prevent burnout and to ensure that you work at your best. So make sure that you engage in self-care, to prevent burnout, but also to ensure that you are the best clinician, researcher, and human that you can be. Some of the things that can be helpful are to keep a memento in your mind or in your pocket, like a photo or a message that reminds you about why the field of medicine and diabetes specifically, or endocrine specifically, is important to you. The 34 million people with diabetes and 88 million people with prediabetes need you. Thank you for choosing to make an impact in their lives, and thank you for joining our professional community. I look forward to hopefully crossing paths with some of you in the future, and I hope that you enjoyed this experience and your experience during scientific sessions. Thanks for this time and enjoy.
Thank you so much, Dr. Munoz. You spoke from your heart, and it was wonderful advice you gave us. Hello, and thanks for joining this workshop. We are here to discuss some trade secrets about optimizing your fellowship in your second year. We have two esteemed guests who are just such shining examples of how much you can accomplish in the field you're so passionate about. Dr. Meltem Zeytinoglu is an assistant professor of medicine at University of Chicago, where she is also a fellowship program director for adult endocrinology, diabetes, and metabolism. Dr. Zeytinoglu's clinical and research interests include endocrine education, diabetes, and osteoporosis, as well as diabetes in older adults. She has been involved with Focus on Fellows programs since it started as she started as an attendee for the first year, and then as a part of ADA's early career advisory group in subsequent years. Dr. Ron Mi Zhang completed her internal medicine residency at St. Louis University and endocrine fellowship from WashU in 2017 and has remained on the staff at WashU. She's currently active in translational research evaluating the role of inflammation in diabetes, in addition to both inpatient and outpatient clinical responsibilities. Welcome both. And to the audience, I'll say that this is an interactive session and is designed keeping an open format in mind. We welcome questions. We actually encourage them. Please bring those questions. So let's begin. This question is for both our speakers. How do you describe your professional roles and responsibilities and give us a rough estimate of your present involvement in each role? I'm asking this question to highlight your professional evolution since your fellowship.
I can go ahead and get started, and thank you, and I'm excited to follow up after Dr. Munoz in her passion. I think, the fact that you all have chosen to be endocrine fellows and diabetes specialists when the burden is so great in the population, and it's not always an easy profession. I really want to commend all of you. That's why I'm here, because I share your passion, and I want to help develop as many diabetes specialists as possible. And so that's really what drove me. I just in a very brief summary, I did my fellowship training where I am at the University of Chicago, and I had intended to do a 3-year fellowship with an interest in research, clinical trial research in particular. But when I was in my very beginning, I should say, of my 3rd year, a faculty position opened up, and I was invited to apply for that position and encouraged to do it. And it was a clinical position that perfectly mirrored my clinical interests. And so it was a difficult decision because I knew that once I got into a clinical position, I would still absolutely be able to do research, but that protected time would be much harder to gain once I started a busy clinical practice. But it was the right position at the right time. And so I accepted that position, and early on was very motivated. There was no associate program director position in my fellowship, but but was eager to sort of start some new didactics and new things. And so I helped my mentor, who happened to be the fellowship program director. And then that gradually evolved into me becoming the program director as she was ready to step down. And so that's just a brief summary of how I got where I am.
Thank you. Dr. Zhang?
Yeah, so actually, I started my fellowship here at WashU in 2017. I graduated, I guess, technically in 2019 with my 2 years of clinical fellowship. I did go on to do a third year as well. And so, this year was actually my first year on my own. And my time has mostly been spent 75% protected time to do research, and then 25% I still maintain a half day of clinic and some inpatient duties, and I did some internal medicine. And it's been a wonderful year, and I've really appreciated that time. Most of my time right now is trying to work on my project and submitting papers and writing grants to try to prepare for a research career development award. But everything the third year was something that I had planned probably starting my second year. So these are things that are available to you if you are interested.
Thank you. So you see, we have examples of a clinician, educator, researcher, combination of everything. My next question is to Dr. Zaitinoglu. How did you get interested in clinical education, and what foundations did you lay for the same during your fellowship?
Thank you for the question. And I just realized I forgot to mention my percent split, which is right now I have 5% protected time for being a program director. There are various administrative and teaching planning things that take some of my time. I spend 2 days in the clinic with a very complex patient population, a very sick patient group. And then I spend the other amount of time on some focus on older adults and research and some clinical trials there. Time management is a skill that I continue to work on. And I think that's really important to work on in the later part, especially of your fellowship. In the first year, you're just trying to kind of stay above water, getting your feet wet with some research, and of course, very busy inpatient loads usually, as well as clinic. But in the second and third year, you start to mirror a little bit of what you'll do if you stay in a mixed role. And so time management is definitely something that I think is important to start to think about in fellowship. I was lucky to be at a training program, as most of our training programs are, associated with great medical schools, and so was always interested in teaching. And we have a medical student course in as all med student schools have. We have a brief period in endocrinology. I also direct that right now. And I started my endocrine education interest there. I was a preceptor for a lot of the labs. Traditionally, they were run by some faculty, and I asked if I could help with those, and really kind of asked about where I could help support teaching as best as I can.
So you started pretty early on, trying to zone in on your interests. Is that a correct way?
Yeah, absolutely. And I have to say, I didn't plan on becoming a program director, at least at this stage of my career. I'm now in my 6th year as faculty. And so I thought that was something I would definitely work towards at some point, but I had no idea when my mentor would want to, step down, or if I would be chosen as program director. But that's where being sort of motivated can help a lot, because as I said, there there was no associate program director position, but I was doing a lot of things to support my mentor just because I was interested in teaching. I had started a new new fellows boot camp for our incoming fellows. And so they said to me at that time, you know, we don't have any protected time to give you because this is not a position that's been there before for associate program director, but you kind of earn the title by you know, just being motivated and asking to do things. And then that was a very natural way for me to, so although I didn't get the protected time in the beginning and I put in some extra work, which was not always easy, but that led to a really wonderful opportunity. And so, you know, having that mentorship, which is something that we've talked about a lot, and also offering help just because you're passionate in something. I mean, time management also involves saying no and not doing more than you can do, but this was something that I was particularly passionate about. And so that's part of how you sort of manage your time, is really focus on the things that you want to work for the rest of your career. You're beyond the stage where you have to say yes to everything. I know it does not feel that way. It still doesn't feel that way, but certainly I've gotten a lot more comfortable at saying, you know, thank you for the opportunity. I don't think I can do this, but here's a person I think might benefit. And that's how you sort of pay it forward as well.
Thank you so much. Dr. Zhang, what made you pursue the third research year? And you said you probably decided on it in the second year, right? So just lead us through your thought process.
Yeah, so I knew early on in residency that I loved, you know, when you come across a clinical question, being able to at least try to answer that question. I just found that very exciting. I really wanted research to be part of my career somehow. So early on, I found a mentor who was very supportive and a project that I was interested in. So late first year, early second year, I reached out to my mentor, started discussing the possibility of doing third year and what are the steps I need to take. And I did a third year for several reasons. One is to gain more research experience, both clinical and in the lab, because I do translational research. Two, like Meltem said, it is really hard, especially the first year, but even sometimes second year, you have a lot of clinical responsibilities to find that time to generate the data that you need. So that third year buys you time to finish your project. And if possible, you know, try to at least as soon as you can submit just a paper so that when you apply for the Career Development Awards, you know, you have something under review. That's very helpful. Also, when you decide on a research career, that third year can really be an important time for you to find your own independent focus. So what you want to do is take the preliminary data and the project that you're doing with your mentor and think about what can I develop that's related to it, but separate, that I can develop into a career in the next 10 years. That's very important. And finally, it takes time to submit grants. So that third year, you can be writing grants and starting your first submissions. So what I recommend, just like Meltem said, you know, time management, make a timeline of things that if you decide to do a research year, make a timeline of things you want to accomplish. You know, these are the grants I want to apply for. These are the things I need to finish my project. I want to submit a paper around this time, abstracts that you want to submit for. You may not reach all your goals, but having a plan is really helpful.
Can I just jump in and piggyback on a couple of things? You know, fellows are so often so hard on themselves about, you know, having the perfect research. And I absolutely agree. The more you can get done to plant a seed for career development grants during fellowship, and that extra time really helps you, the better. But I have seen that research doesn't always go perfect. And for various reasons, for mentorship, even COVID really got in the way of some of the clinical work that some of my fellows were doing. So don't get discouraged if research is still what your heart is in. You know, for me, it's really important that you learn methodology more than anything. So you're learning how clinical trials are done, or you're learning the wet lab techniques that you might need to answer the questions. And networking is also really important, because so much of research is collaborating. And, you know, you may not have the skill set for something, but you may know the question you want. And so knowing who you can go to to. There are options for even, I had a fellow last year who did a fourth way. We call that a pathway to instructor position. So she did a fourth year to gain additional, lab and publication experience. Now, obviously, we don't expect you to do unlimited training. I know that, and we've got loans to repay and all sorts of things. But if your heart is really in research, and for whatever reason it doesn't go perfect, just speak up and really let your program director and your mentors know that you still want to do this, and help you refocus if needed.
Thank you so much. Many of the fellows start thinking about like building their own niche, like whether it's diabetes, obesity, metabolism, thyroid. So how do they start building that portfolio, if you will? Any tips? And this question is for both of you.
I think it's many fellows come in with interests. They know they love the thyroid, for example, or they love diabetes, and then some programs have areas. My program, for example, is especially strong in thyroid and genetic diabetes and type 1, but we don't have as much adrenal and pituitary, for example. And so some fellows who are kind of undifferentiated, they gain interest in what they're most exposed to. But in my own example, for example, my diabetes is still my first love, but I do 50% osteoporosis, and I was interested in diabetes in older adults and endocrine health in older adults. And so the faculty position I was offered, required that I do 50% osteoporosis, and then I could do diabetes in older adults as well. So I grew to love it just by what was around me. And that doesn't work for everyone, but I really do enjoy bone disease, and my research interest is bone fragility in patients with diabetes. And so it's really just sort of taking advantage of what is in front of you, and possibly, also just advocating for what you love. I made it very clear I would love to do this bone position, but my contract has to say I'm still doing 50% diabetes, because that's, that remains my great interest.
Yes, and I would agree with that. I would say one of the goals that you should try to set your second year is maximizing your areas of clinical interest. If you can identify that early, even if you want to do research, we're still clinicians, and that is, our bread and butter. I think if there was one thing that I wish I could have done better my second year, would be being more deliberate about seeking opportunities to enrich my experience and knowledge in my area of clinical interest. So if you're interested in thyroid biopsies, go to extra thyroid clinics. If you are interested in bone, there are endocrine fellows. Fellow Foundation has this metabolic bone conference. If you're interested in diabetes, spend some time with the diabetes educators. They're a great wealth of knowledge, but just be deliberate. I think that's very important.
That's a really good segue into something that I really want to mention also. On the one hand, we're saying expose yourself and do a lot of things, but fellowship is a really unique time where you get more time than you'll ever have likely as an attending again. It gets really hard, whether you're clinical or research, you're pretty busy in a different way. So one of the things, whether you know what your interest is or you're not sure, I cannot recommend this enough. Go to every meeting you can, even if it's not something you're super excited about, because you have, number one, a little bit more protected time, and you can always ask your program director, say, this is something I'd really like to attend. It's really hard to attend a lot of meetings once you're, in clinic or have a lot of lab meetings. The other thing is there's a lot of subsidies, like the ADA, where, they do such a nice job through this program of subsidizing your your registration fee. And as an attending, meetings become even more expensive. And even if you have the time, you may not have the budget to attend everything. So really try to attend, especially in your second and third year when it's a little bit easier, as many meetings as you can. And that'll help you grow your interests too.
So thank you both. Now there's a question from the audience, and I'll just read it out. And Dr. Zainoglu, you can go first, and then Dr. Zhang. Do you think it's possible to still develop your niche after fellowship?
Yes, absolutely. So again, I don't mean to refer to myself at all over and over, but my own experience is an example of that. I did not, because I didn't think that bone was my primary interest in endocrine. I got my usual experience that the average sort of endocrine fellow would get until the very end of my fellowship, when I actually did attend, once I knew I would become a bone specialist, the Endocrine Fellows Bone Conference, which I cannot recommend enough. It was a great experience. But then I learned on the job, and I learned, as a junior attending, I became an expert in bone along the way. So certainly you can definitely continue to learn after fellowship. And again, there's lots of didactic opportunities, and you don't have to know exactly what you want to do. It helps. It's nice if you do, but a lot of times we evolve during faculty based on what's available around us.
Dr. Zhang?
Yeah, I mean, I would say I'm early enough in my career where I'm actually going through this right now. And I feel, because that was one of the things I wish I had done, and I wish to impart on other fellows now is, taking advantage of your second year if you can. But yeah, I mean, I feel like, I'm lucky enough to be at an institution where if I want to, for example, subspecialize in diabetes, I have people who are, relatively, considered experts in the field that I can reach out, that I know. I just have to be more deliberate and about, what kind of educational resources that I need to seek out now after training to, become an expert in that area. But definitely. And, some of these, I feel like some of these areas of clinical focus may also evolve depending on the job situation. Like Meltem said, maybe your division will require somebody who specializes in a certain area, and you're like, oh, that's a great idea. And then you become an expert in that area. So we're constantly learning. Nothing is set in stone.
So that provides actually a lovely segue to expanding our training beyond just endocrine. Can we just talk a little bit about what other potential pathways are there to boost up your CV, your learning?
Dr. Zhang, I know, well, actually, no, Dr. Petham, this is in your program that you do. Can you tell us a little bit about your lipid experience that you do in your own program?
Yeah, so I, 2 years into my fellowship, I felt like I needed to learn more about lipids, and I certified in American Board of Clinical Lipidology. And I brought that concept to the department. And I think since last 2 years, all our fellows are, trying to get the NLA certification, the ABCL, American Board of Clinical Lipidology, and you become what we call as lipid specialists. And of course, this year, we also had fellows who gave the obesity boards. All my third-year fellows have given obesity boards. So that boosts up really the CV. And I think last year also one of my fellows gave the obesity board. So, you're expanding your expertise. That's one of my recommendations. Other options are there too, right? You can get certified in densitometry. Dr. Zaitnoglu, you mentioned hypertension boards as well, correct?
Yeah, absolutely. So, depending on what you want your niche to be, for example, if it's women's health, you can be certified by the North American Menopause Society in postmenopausal management. I'm a certified clinical densitometrist, or CCD, because I took the bone density certification exam, and you can do that. There are hypertension boards at the University of Chicago. We actually have 2 advanced fellowships. So historically, some of our third years have elected to stay on for a third year to become better trained in hypertension, endocrine causes, and general hypertension, cardiometabolic. That's a luxury that not every program has. And many years it's filled by cardiology and nephrology trainees as well. But certainly it's also a really nice way if you cannot be funded for a third year through a T32 grant. That many of our fellows use, looking for other advanced training, whether that be preventive cardiology, if you want to do, cardiometabolic risk, hypertension. We have an advanced diabetes fellowship that's relatively new, so we'll have a third year who's going to do that next year. So there are all sorts of certification exams. I love the idea of the lipids because not everyone gets it. Some of the lipids are managed by cardiology, and not all of our endocrine fellows across the country get enough lipid exposure. So this is a really good way to give yourself that extra expertise. So, even if it's not going to be your subspecialty, if you have the time or interest to learn more, it's a good opportunity, and it's a good way to sell yourself for a job that you have this additional training and give yourself that selling point as well.
Yeah, and I'm sorry.
Good.
Just to piggyback on something that Melton was saying, finding funding mechanisms for the third year, if you are interested in research, like she said, many institutions do have the T32, which is for postdoctoral research. But if you don't have that in your institution, speak to your mentors, because there are other funding mechanisms. There are a lot of institutional funding mechanisms. For example, at WashU, we have something called the Dean Scholars, or there's many institutions have a KL2. And these are smaller awards, typically 2 years, but they buy you time. And I'm sorry, I don't want to scare anyone into thinking you have to have a publication to apply for a career development award. I don't have one right now, and I will have a career development award, at least institutionally, right now. So, those are the best case scenarios, but don't worry, things do not go as planned, and you can still make things work. The most important thing is having, knowing what you want, being open and communicative with your mentor and your division. And a lot of times they're very supportive towards your interests. So
we have 2 minutes left. So I'd like for Dr. Zhang to say just final words of advice, and then Dr. Zaitnoglu.
Yeah, like Melton was saying, the second year, it goes by very quickly. I think the most important thing is think about the priorities that you want to accomplish. It's very busy. Think about the clinical, the personal accomplishments that you want to accomplish. Also, of course, boards. We didn't get a lot into board preparation during the session, but any of us will be happy to give any kind of advice. But just make a list and prioritize, and make the most of that time.
I agree. Fellowship is one of those special times, kind of like college, where you look back and you're like, wow, I had so many unique opportunities. And in some ways, I wish I could do it over again and do even more. Obviously, you're excited after so much training, you just want to finish, but I would, and totally understand that. You want to start making a salary. Just pause and take advantage of as much as you can, but know that we're not perfect. And even after fellowship, you'll have a lot of great opportunities if you remain motivated and continue to seek mentorship and experiences.
So I'm truly thankful to both of you for being here, for sharing your experiences, opening your heart. This was very valuable. And, you always go back and say, I wish I had done that. I wish I had known about this. I hope this session has provided that. So thank you so much. Now we will transition to our next session. I have the privilege of introducing today's presenter, who brings a unique perspective to our discussion about understanding data, EMR research, or QI intervention. Dr. John Cutback works with a team of analysts at AGMA who use EHR-derived data to create more meaningful quality measures. The team works with AGMA member organizations to use these data to improve population health and reduce the overall cost of care. Dr. John Cutback received his MD and PhD from Indiana University and did his residency in clinical pathology and informatics at University of Florida. If you have any questions for our presenters during this session, please type them into a Q&A box, or please raise your hand button. We will hold Q&A session until our Q&A sessions, and we'll get to as many of them as we can before our time's up. Now let's get started.
All right, well, thank you very much. Appreciate the introduction and the opportunity to talk with you all. I'm not sure exactly, I've never done one of these before, so I thought it might be helpful to begin with a little pontification. Just some examples and some things that might be useful for a subsequent discussion. So I think we want to encourage, let's make this as interactive as possible. But first, let me give you just a little bit of background on AMGA, the American Medical Group Association. We represent multi-specialty, multidisciplinary medical groups. We have about 400 members. And what we do is we advocate and educate and innovate. We're a not-for-profit trade association, so our members are organizations rather than individuals. And our advocacy is around aligning payment incentives for population health in risk-based models. So the idea of moving the whole system from volume to value. And then we help our members with all of our programs redesign their delivery systems to manage population health. So our 400 members comprise about 175,000 physicians. They tend to be rather larger organizations. And we do learning collaboratives, we do research and implementation science, and we do national campaigns. We just concluded our Together to Goal campaign, in which ADA was a key partner. Our goal was to improve care for 1 million people with type 2 diabetes. And our members actually hit that goal at the end of 3 years. And they've spent the last 2 years just sort of hardwiring some of the improvements that they came up with during the campaign. So let me start with just a few comments, and you can interrupt with questions, or we can, I should leave plenty of time for conversation at the end as well. So let's talk about EHR data for research and QI, because I'm hoping during your fellowship opportunity, you will have some opportunity to work with EHR data from your institution, the people who manage those data. And I think there's really a lot you can do. And that's why I want to present a few examples of just stuff we've done at AMGA. And of course, we have the advantage of looking across a number of our organizations. Through a partnership with Optum, we have EHR data, longitudinal EHR data from over 20 of our members. The EHR gives you a view into clinical process and outcomes, but you have to remember that it's through a lens that is affected by billing practices and how the EHR is implemented and used. So for example, different organizations and different EHRs might use or manage the patient problem list and the med list somewhat differently. They might code all of the items on the problem list. Some people may use SNOMED, some people may use ICD. So lots of lots of differences there, but in general, this is an example of kind of what's not standard about EHRs. But still, if you use the longitudinal data from a given organization, you usually can use that pretty well. Most quality measures, if you think about it, are cross-sectional snapshots. The EHR providing a longitudinal view is a really important aspect and something you may want to explore as you do research or even quality improvement. So as we got started on Together to Goal, we found that groups were quarter over quarter improving glycemic control. We were using 8 as a good population, A1C of 8 as a good population threshold. They were only improving about a percent. So maybe 65 to 70, 65 to 66%, 69% to 70%. Per quarter. And we thought, gee, for all the work they were doing. So we looked at the longitudinal data and found out that it's actually a little like trying to fill up a leaky bucket. They were bringing 9% of their people with type 2 diabetes into control during a quarter. But at the same time, 8% of people who had been in control were slipping out of control. So this leaky bucket effect can, and the only way you can tell that sort of thing is to look at it longitudinally. We also needed the longitudinal data to estimate the number of people whose care was improved. Also, I'll talk a little bit about descriptive analysis, variation across and within organizations, and a regression model for SGLT2 inhibitor prescribing, and then give you just a little advice. But let's take a look at some data around screening for diabetes. Now, these are the criteria, as I'm sure you know, and about 70-75% of the typical adult population is eligible for screening. Now, the first lens issue is to remember that the people in the EHR are those who received care at a certain provider organization. So you can't draw inferences about an entire population. So when you look at public health databases, those are a different denominator than the database of the people who received care. Also recognize that many things differ regionally as well. So who was screened? We started with about 5 million patients. About 76% of those were eligible for screening by those criteria. And what we found was among patients 18 to 75, and we had some exclusions, across 23 organizations, we had about 45% of patients who had been screened within the past 12 months, and another 10.5 who had been screened and found to be in control over the prior 12 to 36 months. So no result indicative of either diabetes or prediabetes. So one of the things we always do at AMGA is look at variation across our member organizations. So the number 55.3% of patients being screened who are eligible is a good average, but notice that that ranges from 47% to 76%. So immediately you begin to get the idea that there may be some organizations, and there could be some data problems here. Remember, these are data that are collected as a byproduct of providing care. They're not part of a prospective research trial. But at any rate, there may be some opportunity to learn. But an interesting thing is if we drill down even further and look not at organizations, but look across all these organizations at the 8,800 individual primary care providers who have at least 100 patients attributed to them, you will see quite a range of variation in performance. And I guess people are not terribly surprised by this graph. But what often surprises people is this graph. If you look at individual organizations, you see this same gradient in screening performance across providers and care teams within every organization. And one of the things that is really important that we've learned is that if you talk to the people here They're in complexity theory, they're referred to as positive deviants, people who, with the same resources as everybody else, wind up doing better than everybody else in terms of their outcomes. It's better to talk to these people at the outset than to start browbeating these people. There may be reasons that these people should not be screening for diabetes, but there may also be reasons that they should. It's just better to have a sort of a pull arrangement from these folks up here who are doing really well, and they'll often be very willing to help folks who are doing less well in getting this critical screening process going. Just an interesting thing, though, if you look a little farther into the data, let's figure out, if we're not able to screen everybody, are we screening the right people? So, for example, if you look at the screening yield, so you can see that it varies by weight category, and the yield for people who have obesity class 3, BMI of 40 or over, is actually 6 times as high a number of people who have a result in the diabetes range. Obviously, you need symptoms and clinical confirmation and a repeat test to diagnose diabetes. But at any rate, the people who have these results in the diabetes range 6-fold higher. So if you were to screen a subset of the population, what you should logically do is screen people with higher BMI. But as we see, looking across all the organizations, that's not really happening. So a lot of organizations think they're screening the high-risk patients, but in fact, they actually aren't. And we see that over and over as we look at different measurement and screening opportunities. You can see the yield by weight class is essentially the same kind of pattern at every one of these 23 organizations. You can also see that the screening rate by weight class is the same pattern for every one of the organizations. So nobody is preferentially screening patients with high BMIs, even though the yield of that screening process is 6 times greater. What about insurance, Medicaid versus commercial, which is likely to reflect socioeconomic status? Twice the yield, but again, the screening frequency is going in the other direction. Similarly, if you impute education level based on a zip code, you will see that the percent of population with a bachelor's degree, the folks at the low end of that scale, twice as likely to have a result in the diabetes range. But again, the screening is going in the other direction. So for quality improvement, an examination of data like this can give you some very quick and immediate things that you can do to improve care. People with obesity, higher yield, people with Medicaid insurance, but still only 44% of the people eligible for screening who aren't being screened. So let's learn from those high-performing care teams. Now, another example is using regression models. So this is not just looking at raw data and raw outcomes. This is controlling for some risk factors. So as you know, SGLT2 inhibitors are recommended for people with ASCVD, heart failure, or CKD when the GFR is adequate to control glycemia and reduce cardiovascular risk and slow the progression of kidney disease. So we looked at EHR data for about 250,000 patients with type 2 diabetes who had an ambulatory encounter with a primary care provider and at least one prescription for a glucose-lowering medication other than metformin and insulin in the past year. And of course, we excluded people with ESRD and hospice care. And what we did was use logistic regression to describe the differences in SGLT2 prescribing by eGFR category, comorbid conditions, specialist visits, after adjusting for all of these other factors. So this is something that's relatively straightforward to do with EHR data. And here's what you get as a result. You get a what's called a forest plot, which shows you essentially the odds ratio for each of the categories that you have defined with after controlling for all of the other things that are in the regression model. So here's an example. The reference rate is people with a GFR of 90 or higher. And actually, people with mildly reduced GFR, early CKD, should be getting, they should be more likely to be getting SGLT2s. Now, obviously, when the GFR goes below a threshold, then they should be less likely to be getting. But here's an area where, from the Credence trial and other data, we know that there could actually be a good deal of help, but we're seeing the actual practice go in the opposite direction. We are not seeing people being significantly more likely to get an SGLT2, well, maybe marginally significantly, because I guess the confidence interval doesn't overlap one, but they're a little bit more likely, but they're also a little less likely if they have heart failure. So again, these recommendations do not seem to be adopted even after controlling for all of these other factors. But one of the things I think you should all feel very good about is the thing that gets them the highest improvement in the odds ratio, almost twice as likely to be prescribed an SGLT2 inhibitor, is having at least one visit with an endocrinologist. Now, it looks like the nephrologists are a little reluctant to start medications like this, but at any rate, I thought this was just a kind of an interesting way to look at things. And if we want to look at other factors, these are all in the regression equation. So patients who are older are less likely to get SGLT2s. Medicaid and Medicare, probably an age effect, maybe a coverage effect for Medicaid. Ethnicity, a little less likely, but race. We do have statistically significant lower likelihood of getting these recommended medications for African Americans and Asians. And then there's a small difference by sex as well. So just an example of using data like this. This is from the same data set, prescribing glucose-lowering medications by age. So these are patients with type 2 diabetes who are, and in this case, we included the people who are receiving insulin, but we still excluded the people who are only on metformin. So you kind of wonder why there's such a high proportion. This is saying like 40-some% of patients in the 20s and 30s are receiving insulin. These could be people who are initially diagnosed with a very high A1C and being put on basal insulin for temporarily. It could also be that we fail to exclude some insulin use from inpatient stays or something like that. But at any rate, it is kind of interesting. You can see less use of GLP-1s and SGLT2s in older patients. Many of them are already on sulfonylureas and stay apparently on sulfonylureas. DPP-4s, not much age effect. And TZDs, obviously less used, but again, maybe some people who've been on a TZD for quite a while. But at any rate, just interesting things you can do with the data that cause you to think about different aspects of your prescribing process and what people within your organization are doing. So exploring just some tips, just 3 tips here for use of observational data. Exploring the data to validate your assumptions about the lens you're looking through. So are you seeing the outcomes you're looking for captured consistently in the EHR? Do the rates look about right? It's really helpful to look at distributions, not just a mean plus or minus standard deviation. Understand the shape of the distribution, look at the extremes of the distribution. Understand the depth and consistency of diagnosis coding. One of the things you'll learn is that diagnoses that lead to higher payment are more likely to be coded. And you've probably had some experience with people interested in getting coding done that drives HCC, hierarchical condition category classification, because that's how Medicare Advantage payment rates are determined. With observational data, this is not cheating. It would be maybe cheating if you've got a well-designed, randomized, prospective experiment, but that's not what you have with observational data. It's only prudent to evaluate the data and make sure that they look the way you expect them to, and there isn't some bias that the process of recording them and capturing the data in the EHR isn't introducing. You have to understand those potential biases. It doesn't mean you can pick and choose data points once you're done. You still have to treat them in a very, very consistent way, unless, of course, you're in politics, in which case I think that's expected behavior. To improve quality, you want to find and learn from the positive deviants. As we see, there are always some people in every organization who are doing well, usually with the same resources. Maybe they're not just prescribing the right drugs, but maybe they're focusing on medication adherence in ways that other people aren't. Maybe there are other things they're doing that aren't obvious, even from the data, but lead to better outcomes. And then the final point of advice is to appreciate the analysts who receive and process the data. It's really helpful to just have a conversation with those folks. Don't fill out a query form and ask for a data set and just blindly use those data. Think about what you get, but specifically talk to the people who understand where the data came from and how other people have used the data. But anyway, just a sort of a quick summary of a few thoughts about ways to approach using data, both for research and for quality improvement. Happy to entertain any discussion, have any, whatever seems like a reasonable question.
Thank you, Dr. Kalbach. It was truly valuable. Now, I have a few questions. When you use observational data from EHR, we, of course, cannot randomize. But can we find a control population so we can compare outcomes for patients who received a certain intervention versus patients who did not?
Yeah, that's a really good question to raise as we are using observational data. You can never get the full benefit of randomization from observational data, but you can, and it sort of gets down to how do you tell the difference between association and causality, correlation and causality. And of course, you can't be sure, but you can improve your understanding substantially by doing something like propensity score matching. So just in concept, what propensity score matching does is you develop a predictive model for the outcome that, say, the drug intervention or whatever intervention is trying to prevent. This just sort of a typical setup for something you'd want to study, a question you might want to ask. And so you're trying to prevent some certain thing. What you want to do is figure out how likely, what's the propensity for an individual patient based on any data element you have in the EHR to have that outcome. Then you match patients who had equal propensity scores, but one of them actually received the intervention and the other one didn't. So they're equal in propensity, absent the intervention, to have that outcome. But the difference is some of them had the intervention and some didn't. So that is an accepted mechanism. There are lots of different ways to develop propensity scores and philosophies about how to do that. And you can do sensitivity analyses always to see whether your model made a huge difference in the outcome. But at any rate, that is a very commonly used way. It's accepted in the literature. You can get things like that published. And it does take advantage of the fact that you've got all these data that are captured as a byproduct of providing care.
So it's very interesting. You said that I wish I'd heard this talk during my fellowship or early on in the career, are working on something, the quality improvement, where we were comparing retrospectively the data, and finally it got accepted. But and we did use a propensity score matching finally. But what would you say to fellows and early career faculty who do not know statistics, and where to look for that, like, to have that support system in place so that they can then focus on designing the experiments, and then someone else can analyze it or help them design it?
Yeah, I think it's interesting to sort of watch the evolution of the biostatistics consulting operation that most academic centers have, because the people who have traditionally done that kind of work are experts at doing things like power calculations and the very strict methods that are used when you are designing a randomized trial. I think what we're seeing an emergence of is this whole idea of the field of data science, of using observational data. Now, I always get a little concerned when people say, well, there's so much we can do with sharing data in other organizations, or we can analyze data in other industries. Like I can use my debit card, anywhere in the world and it works. And why can't we exchange electronic health records? And it is true that that healthcare has sort of underinvested in information technology. But at the same time, it's also true that healthcare data are way more complex than financial data or marketing data or web clicks or anything like that. Those are such well-defined things. But I think we are beginning to see some of the data science that was developed for those very large data sources infiltrate into healthcare, and tackle the real uncertainties of how data elements are defined, and using the technologies that have been developed in these big data tools to actually try to understand, can we figure out if there are some biases in the way things are recorded, account for those biases in the design. And then the other thing that I think is, and anyway, that sort of philosophy, it would help with the kind of approach you're talking about. I think the other thing is people are getting a lot more comfortable with pragmatic trials. Started with adaptive trial design for, so that you don't have to carry even a randomized trial all the way to the end. If you're learning something early on, you can adapt the trial, the remaining parts of the trial. Also, pragmatic trials are getting much more popular, more publishable than ever before, just because it's completely impossible to do enough randomized trials to answer all of the questions that are going to arise in everyday practice. So we still need those for the base, very narrow questions, so we can get really clear answers on those narrow questions. But at the same time, the implementation science, the application of those findings in the real world, there's a lot of opportunity to do pragmatic trials around that kind of application in that work. And it's becoming recognized as a much more legitimate thing to do, rather than just something you do kind of out of your back pocket to see if you can improve quality in your local organization.
Thank you. I think we have time for one question, and how can we forget the pandemic, which we are still going through? Have you used EHR data to track changes in care during the pandemic?
Well, I just happen to have some slides, but I'll go through them very quickly. It's just interesting to see. This is for 21 of our members. And we're looking here at visit rates for 2018, 2019, and then here comes 2020. So a 10% larger population from 18 to 19, a 15% larger population, and then everything bottoms out. But it is really interesting how quickly people recovered. Now, this only goes through September. April obviously was the lowest month. But if you look at different organizations, you can see that while it was a 40% decrease on average, some organizations only hit a 32% decrease, others a 52%, and then some actually rebounded fairly quickly, some rebounded much more slowly, and some, really settled at a fairly low rate and this is, these are organizations distributed around the country, and what's happening in the pandemic locally is reflected right here in what happened. You can look at differences. People with Medicaid insurance, we actually have less of a dip in the rates than we do with Medicare and Medicare Advantage, which is the commercial over 65. And then I think it's just fascinating to look at these ranges. So elderly patients were very scared to go to the doctor. Medicaid patients tend to be younger and maybe sicker and have more immediate needs for management. So you can see here's the age effect, big decrease in April, but a recovery after that. Race and ethnicity effects, you can see the larger decreases. Household income, less decrease in lower household income, although this isn't nearly as steep a gradient. The people who had their last A1C, what their value was, their last A1C in 2019. The people who were under 7, much less likely to visit. People over 9, more likely to visit, less likely to not visit, I guess, in April. So you can see some of those kinds of differences. The proportion of visits that are telehealth turns out to settle about 10%, but it went to somewhere between 13 and 90% during April. Now, this is of a reduced number of visits, but wide range in the percentage of those that were by telehealth. And I'll just finish with this one. Looking at primary care, we saw that 65% of their visits during April were via telehealth. Looking at endocrinology, 82%, so even higher than cardiology and nephrology. So settling at 10% overall with primary care, about 20% for endocrinology in September. And we've actually run these data through the end of the year. And this consistent number is pretty much maintained. So just a little bit of a glimpse into what the pandemic has done to volumes and the way we care for patients and who was actually still getting care.
Thank you so much, Dr. Cutback. I learned a lot, and I'm sure the audience did too. Thank you for sharing your data,
Sure.
your perspective. If you have just joined, let me welcome you. We are here to discuss the first steps in job expectation and job search. After a grueling undergrad, residency, and fellowship, this is the first time we are stepping out of to practice on our own, right? So it's my pleasure to introduce Dr. Aurelia Wood. She's an endocrinologist at Nationwide Children's Hospital and an assistant professor of clinical pediatrics at the Ohio State University College of Medicine. She obtained her medical degree at Wright State University Boonshoff School of Medicine in Dayton, Ohio. She completed her pediatric residency at the University of Louisville School of Medicine in Louisville, Kentucky. She's double board certified in general pediatrics and pediatric endocrine and diabetes. She is the co-director of the Type 1 Diabetes Program and a co-medical director and co-founder of the Diabetes and School Health Program. In her free time, she enjoys hiking, cooking, walking, watching, and playing tennis. You can often find her and her husband hanging out at homes with their dogs, working on home improvement projects, watching movies, nurturing their growing collection of plants. Welcome, Dr. Wood.
Thank you for that warm welcome. All right, perfect. Well, I can't see you any longer. So of course, I know the chat will be moderated. So if you have questions, feel free to interrupt. But as was stated, this is a brief talk about a very important and heavily weighted topic, finding a job, that last step, and the expectations for the first job. So it's one of those conversations that you want to have over coffee with your mentors, with your colleagues, with fellows that have graduated ahead of you, because there are so many different considerations. We all have different career paths and different interests. We may be clinician educator focused. We may be focused on QI or research. And this talk will mostly, especially once we get to what to do once to get to the job, maybe focus more on academic, because of course that's my perspective, but certainly we'll have information that'll be helpful for anyone, no matter how they're navigating through and what their career intended path will be. So we all have different ways that we think about making big decisions. What's my job going to be? What am I going to do once I've finally completed that last milestone in my academic medicine training? Some of us may be more conceptual, and we have a vision for what we think we want our career to look like, and we let that guide our decision making. Some of us may be directive, and we might see what we want, know what we want, be able to make quick decisions. Some of us may be more behavioral and really consider our relationships and the dynamics of all the different personal, professional considerations before making these kind of decisions. And some of us, self-included, are analytical, and we kind of sit back, are a little bit comfortable with that ambiguity, and really navigate through making decisions by carefully examining all the different aspects. But no matter what your perspective is, no matter what your career path is, I'm hopeful that this talk will help you at least have some objective milestones and information to guide you on that path, make it a little bit more clear, and get you towards that goal of getting towards your career path. So first year of fellowship, of course, your main concern is being a fellow. You go from on June 30th to being a pediatric resident, an adult medicine resident, or whatever your primary residency was, to an expert in endocrinology. So of course, your main focus is that clinical piece and becoming a expert in your new specialty. However, we do want to start thinking about this part, this career development, even early on. Some easy first steps to take are suggested here, including making sure your CV is updated. At this stage, when you're in fellowship, you really will be concluding things from residency and medical school, may no longer need to include things before that time, unless they're very big, very impactful, or somehow really directly related to your current career path. You also want to start to do some brainstorming, which your program leadership will help guide you with doing, about what your QI and your research projects will be. And as a part of that, you should really start looking at that conference calendar. So all the different pediatric endocrine associations and organizations, really looking through their websites, getting really familiar, and finding all those different conferences that will take place. Not only are they excellent opportunities for learning, but they're great for networking. Unfortunately, we're doing that virtually, but still there are opportunities here because we're still gathered together in a large group. But that's a great place that I found during fellowship to meet different fellows, to meet attendings and faculty from different institutions with different backgrounds, different career paths, to really start just getting the wheels turning of what the different options are once you're complete with fellowship. Of course, within your fellowship, you'll begin identifying mentors, but also start to think of those people as someone who will help you with your career development, not just your research, not just your QI, not just your clinical work. By the wintertime, you want to revisit that CV. You've probably done at least a few presentations. You may have gone to a diabetes camp or done some other experience. So keeping that updated as you go along is really important, because you might get 6 months down the road and forget all those great things you've done. So the best way to keep it updated is to do it at least every 6 months, optimally updating it as you go. So you give a lecture, put it on your CV that same day. That's also a good time to just casually familiarize yourself with the job boards that are available, so that the first time you're seeing them isn't when you're actually looking for a job. So there are various job boards that are available that have like a gross perspective of available positions. Of course, the American Diabetes Association has the Pro Career site, which has a really nice navigational tools that really can help you tailor figuring out where are available options and where are open positions for the job that you may want. For adult endocrinology fellows, the Endocrine Society also has a great EndoCareers portal to help find different positions. And then for those of us in pediatrics, the Pediatric Endocrine Society job board is probably the primary place that we go, especially if we're looking for a career in academics. Everyone doesn't go into or stay within academics, so there are other job search navigation portals and other methods that can be engaged as well that function the same way. And we can talk a little bit more about that in the breakout sessions. So once you've kind of gotten to that portion, you're actually near the end of your first year. So what you want to do, of course, at the end of any big milestone, or at least what I find is helpful for me, is really reflecting and then planning for that next stage. And in this context, that includes career planning. So what does that reflection look like? So when you sit back, some questions that you might want to ask yourself are, what's working and what's not working? So what things are going really well? What am I feeling comfortable with? What are some things that I may need? What's not really working? Do I need more clinical experience in a certain area? Do I need more experience teaching? Do I need more experience in some other aspect? So really just critically thinking about what you need and what's not working. And then what do you need? So do you need another mentor? Do you have a research mentor, but not really someone you can talk about personal and professional development or work-life balance? All those things are important and are also important to think about as you are thinking about career development. You also want to think about, after that intense first year of a lot of clinical service, what do you like about endocrinology? And what do you like about medicine in general? Because those two questions will help you maybe begin to answer the question of what do I want to do when I'm done? So if you find you love inpatient just as much as outpatient, you love teaching, maybe you want to stay in academics. If you find that there's a niche opportunity or a niche subspecialty within our specialty that you like, and you have seen someone do it in a way that you find to be very interesting and intriguing, talking with that person and seeing how they got to that space is very helpful as well. And then you definitely, if you haven't already, want to put all that together because it'll help you determine what are your goals for personal and professional development. So a tool that can be very useful in keeping that organized and really sitting down and having reflection is something called an individualized development plan. But not everyone's not that detail oriented. So some people may just want to kind of scribble down, just have an hour or so where you just kind of sit down, just write down what first comes to your mind as you're going through this reflection. Some people may want to talk it out with a friend, with a co-fellow, with their mentor. And some people might just want to, on their own, just really sit back, reflect, and think. Whatever works best for you, I highly recommend picking a time and putting it on your calendar for at least an hour or so to really sit back and reflect at the end of that first year and ask yourself those questions. That individual development program that I mentioned is a tool to help organize, objectify, and plan progression through your goals. So if you look online, there are many templates that are available for individualized development plans. They can be as detail-oriented or as broad as you could find them to be. But I find that this type of organization system with dividing my goals by different category and then looking at the different timelines in the future is helpful to do that. So here we have clinical, research, QI, academic and career goals, and then other, which could be personal or other professional development outside of your primary endeavors as an endocrinologist. And a lot of times doing that reflection of saying, I think I see myself as X, Y, and Z helps you know that 5-10 year, and then will inform what your short-term goals might be. So for the end of the first year in clinical endeavors, you may say, I just want to survive, get through these 6 months, and that's fine. And you all will and probably have. But you may say, I need to increase my comfort with XYZ skill, XYZ diagnosis. With research, you may have specific goals that you and your mentor and your support group are working on, but you want to at least have some goal that's tangible, that has a date attached to it. That way you stay on track, because time goes by very quickly and these 3 years of fellowship progress faster than you can think. And I'm sure those of you that are in that third year can attest to that. But if you are someone who is more objective and kind of needs that timeline, creating a document like this that you can always go back to, update, reflect on, helps keep yourself accountable. So second year, same thing. You want to start out by updating that CV and looking at that conference calendar and plan on attendance. You also want to start thinking about making and updating the materials you're going to eventually use to apply for your jobs at the end of your second year, the beginning of your third year, and start having a little bit more serious conversations with your mentors, with your peers about job considerations. You want to then go back to those job boards and see what's available, see what's in flux, see what may seem attractive to you, just so you have a finger on the pulse of what's going on. And then at that time, you're probably going to be finalizing up your research, kind of heavy in that aspect, still doing your clinical work, but remembering all those contacts you made when you were going on your conference journey. So reaching back out to people who are at the institutions that you may have seen on the job boards that are interesting to you. And then at that point, you want to start really finalizing your application materials by that second spring, because you're going to be applying for your job soon. That's also the time that you're going to want to start requesting letters of recommendation from those who you want to write your letters. So what are these application materials? So as was mentioned, this is kind of the first time that for many of us, unless we've worked in another area before we came to residency and fellowship, that we're going to be actually doing a standard job application process. Eris and an algorithm no longer determine our fate. So some things that we haven't necessarily had to use before will now become important for us. So your CV, as I mentioned before, keeping that updated will be important, and making sure it's in a nice format that's very organized and fluid throughout. So that's going to vary by institution. Every institution will have a different template. So you just use the one that's recommended by your institution and use that as a template. We've all had multiple personal statements by this time, but you'll want to have that just in case the place that you interview asks for one. It's not as universal as other stages of career preparation to this point, but some places still do ask for this document. And of course, the letters of recommendation, with the most important part being timely information and timely requests to those who you want to write those letters. Some of the things that we may not have had to create before include cover letters, and then kind of templates for messages to send to people and send to institutions and send to prospective jobs that are indicating our interest. As it says here on that last line, you want to tailor to each institution and the available position, which is also a little bit different because to date we kind of have used blanket materials. So a cover letter is really a document, a one-page document, about 250 to 400 words, that is almost it's telling the story of what you've done to date and why and what your next goals are in your job. So if you've been doing this reflection, maybe made that IDP, have been talking about what your journey through fellowship is and maybe what you want to do, writing this will be easy. It's not a personal statement, so it's not just your personal account of what's drawing you to the job, but it does allow you to show things that a CV and a personal statement may or may not be able to do. So putting together the journey, so highlighting the things that are important to you, highlighting what your specific skills are, highlighting what kind of institution or position you're looking for, and maybe why where you're sending the letter meets those requirements. So it allows you to kind of tie in both your personal and professional development in a one simple document in a way that the CV and the personal statement do not do. I have a template here that we can certainly share with the group that I've shared with prior fellows and my co-fellows as well, because again, it's something that we haven't had to do. And of course, there are multiple different templates available on different professional development websites. But again, it's really showing the story of who you are in a succinct way and really capitulating what's important to you and what will make you special and what makes you a good addition to the place you're applying to. Some places don't require this, and they may just request information from you, your CV, your personal statement, your letters, and then you'll just send kind of a standard little message along with that. And this is an example of what that may look like. So just a brief introduction saying you were happy to receive notification that this position was open and just asking if they need anything else. So again, we've all asked for letters of recommendation multiple times along this journey. So most of us are familiar with how to do that. But again, at this stage, what makes it a little bit different is that we're going to be potentially looking at multiple different types of jobs. And so we want our letter writers to really understand what our goals are, where these letters are going, so that we have the best chance for success. Because we know that that personal attestation, that personal interaction, that strong letter can really be helpful when we're looking for a new position. especially if it's someone that you're not close to. So let's say you have a really big division and you don't really have a one-on-one relationship with someone, but you think it'd be useful to have a letter for them because you've had positive interactions. It's nice to kind of template out and prepare how you're going to ask them for that letter. Optimally, you'll do it in person. So saying, hey, as you know, I'm starting my job search. I would be, delighted if you would grace me with a letter of recommendation. Of course, most people will say yes. But again, here I have a template for a way to ask someone that maybe you're not seeing in person, maybe they're out, or maybe you don't have as close of a relationship with, but still one that warrants their ability to write you a strong letter out. And what you want to include, even if it's someone that you know well, is where you're applying, what kind of institutions or positions you're looking for, what region of the country or regions of the country you're looking for, what career path you see yourself on. And then you can even give them the list of those institutions. You also want to give them a good deadline. So again, asking far in advance because everyone's super busy and these all tend to accumulate at the same time of the year. If you have an IDP, you want to share them with that. But of course, your personal statement and your CV, especially if it's someone that kind of peripherally only knows some of the things you're doing. So who do you send what? So you'll send, again, your personal statement, CV, plus or minus an IDP if you have one, to who's writing your letters. To potential employers, only send what they ask you for. So if they ask for 2 letters, don't send 17. If they ask you for 2, don't send 1. Make sure you are sending them exactly what they're asking for. There may be places you're interested in applying that don't have an active listing, and it is not inappropriate to still try and figure out whether or not they are potential employers for you. So you've searched on all the boards, you've asked around, you've asked your faculty from other institutions, hey, do you know if they're hiring? And they're not sure. It's always appropriate in a polite, professional manner to reach out to see if there are positions available. So especially if you've maybe had a colleague or another faculty member who has a relationship that could facilitate the introduction, that can be helpful. But again, that may not be the case. So in that case, you may want to just write a brief, succinct letter that includes a short form of your cover letter to briefly introduce yourself, your interest in learning whether or not they have a position, and then thanking them for their time and consideration. Sometimes this can open up doors that were not obviously open, or you may learn that a group is in transit and that maybe a position's not available right now, but it may be. And it's always nice to reach out and to feel comfortable making that step because again, you never know. The worst that can happen is that they say they're not hiring, but thank you for the inquiry. The best is that they could open up conversation and it may lead somewhere down the line. So now we're in 3rd year. So at this point, you've thought about what you want to do, you've reflected on that, you've gone to conferences, you've done some networking, you've done some presentations, you've met some faculty and fellows from other places, you've looked on the job boards, you've identified what kind of career you want and where you want to go, you've prepared all your documents that are ready for submission, and you've requested your letters. So the only thing left to do is send those application materials in. And once you do that, you'll kind of feel like a sitting duck. It's very stressful. It's one of those kind of like push the button, like when you're submitting your ARIS. But usually when you submit an application, you'll hear back within 2 to 3 weeks is usually the general timeline, sometimes quicker, but in general, you can expect to hear back within that time frame. At academic institutions or hospital systems, they'll often either then set up a conversation between you and the recruiter, or you and their HR group, or you and their chief if they are interested in learning more about you and potentially offering you an interview. So that conversation may be like a 15 to 30 minute phone conversation, even pre-COVID, where they just want to get to know you, maybe give you some more details about the position that maybe weren't available in the job listing, and kind of really gauge your true interest. Because of course, people receive many requests, and they receive many applications. So they really want to tailor who they're interviewing to those who are truly interested. But that's also your opportunity to ask questions as well, because remember, you're interviewing them just as they're interviewing you. Again, this is, training is really important. Selecting the right place, the right vibe for a place to train is really important. But training has a deadline. Your first job may not be your last job, but it has the potential for that. So really you want to take that opportunity to ask some baseline questions, nothing too invasive. But if there are deal breakers, if there are things that you absolutely need, that is the time to let them know. You don't want to wait until you get to the interview to say, oh, by the way, my spouse, significant other is a XYZ physician and will need a position. If that's something that is in your journey, you want to let them know those things up front. And that looks different for everybody. And some people may not have any deal breakers or needs, but if you have special considerations or things that may be important for them to know before proceeding further, that would be the time to do it. Thereafter, if they're interested in offering you an interview, you'll get an invitation to do that. If they haven't yet received all of your letters from your letter writers, then they'll request those as well and then formally set up that interview. So interviews. So again, we've done these before for medical school residency and fellowship. And most of us are pretty well versed and remember how to prepare for an interview. We all know that there are certain tips and tricks that we want to adhere to in terms of professionalism, preparation for the conversation, things like maintaining eye contact, just those personal touches, those professional touches that make the interview go smoothly and make you seem professional and help you to be comfortable. But again, this is a different type of situation. And so there are a couple things that are a little bit different. So once you do get that notification that you've been invited for an interview, you want to let your program director know and your program coordinator and your chief. Of course, they'll likely be very happy for you, very excited and very proud, but you want to update them on at least those 3 people on your status, especially because, as we'll talk about in a minute, the interview process is usually a little bit longer. And so you'll need to do some planning ahead in terms of clinical responsibilities. If you feel obligated or if you need to, you may want to also let maybe the nurse you work closely with or maybe your co-fellow know you're going to be out of the office at that time. Or at the least, if you're not feeling comfortable for any reason sharing that you're going on an interview, just setting up that auto reply email so people know, just another level of professionalism. So people aren't expecting communication when you're very busy. And then you don't feel obligated while you're in the interview space to be doing all these different things that could potentially wait until you get back. You'll usually receive the itinerary for the interview process about 2 weeks ahead. Like any other interview, you want to be prepared. At most interviews at academic institutions, you will meet the majority of the clinical faculty. So I would recommend, and some of you may have done this for other interview positions, kind of going into PubMed, going through the website, looking through people's professional profiles on their institution website to get to know who they are if you already hadn't done that. You want to prepare specific questions for your interviewers. There's always questions that you'll probably ask everybody, but you really want to get the feel of what it's like to be attending a faculty at the institution. So asking questions about professional development, about mentorship. If you're a research person, especially, you may have very specific questions about that, but you want to be prepared with questions because every interviewer is different. Some people may have the standard kind of icebreaker, get to know each other, and then have questions for you. But some people may come in cold, sit back and say, tell me what you want to know. So you want to use up that time. You want to utilize that time that they've set aside to meet with you in the best way. You also want to just, again, think back to that story of your journey from fellowship to faculty. So again, just reviewing and thinking deeply about what that cover letter entails and what all you've done thus far entails, so you can really share with them how you think you will contribute to being as a part of their group. At most interviews at academic institutions, you'll be asked to give a talk of some sort during your interview time. So it may be an endocrine grand rounds, it may be a case. If you're doing a research position or looking into something that includes research, they may ask you to give a research preparation. So they will inform you of that when you have that one-on-one talk with the recruiter or the chief, but you want to make sure to practice that a few times as well. So then practical things, of course, booking your travel, making sure you've got a nice, well-fitted suit, a couple different shirts you can rotate out, extremely comfortable shoes. You'll be doing a lot of walking. Again, practicing that talk a couple times and putting it on a non-password protected jump drive in case it's too large to get onto their system. You also want to, especially if you're someone who is more analytical, bring like a notebook to write things down. But I honestly recommend that everybody do this. It's going to be kind of a fast-paced time. You may be a little bit happily anxious, but there'll be a lot of information and a lot of different type of information. And you're going to meet a lot of people on that time. So you want to be able to write down things that when you're reflecting on the interview will help you make decisions about whether or not it's the right place and help you remember things to ask in the next phase as well. Because again, the interview is a two-way street. So you want to make sure you hear from them the things you need to make you feel comfortable that this position would fit you. If you don't have them, it's okay, but I would, if you do have them, advocate bringing business cards with you. Of course, most people are going to have your information, but sometimes you run into someone in passing, or you run into someone who is kind of an add-on to your interview experience that may not have had the full opportunity to review your package in full. So it's nice to be able to have that to hand to them in that moment so that you can keep in touch and communicate. Just another little added level of professionalism. So the interview is a little bit different than our residency and fellowship interviews. Again, for academic institution, they're usually 2 days in length. So the structure and the exact schedule may vary, but many times somewhere between arrival and departure, you'll have dinner with some faculty members. You may even have lunch or a breakfast with the fellows. You'll have a tour of all of the facilities that you're going to be primarily working at. You'll give your talk, and of course, you'll have your interviews. And depending on the size of the faculty and the job you're applying for, you may have a couple interviews, or you may have 2, 3, 4, 5, 6, 7, 8, 9, 10, many interviews. So it can be a very lengthy, somewhat draining process. So again, as much as you can be prepared to be on and be professional and be able to sell yourself and be able to interact and feel comfortable, by all this extra preparation, the better. Some institutions, most institutions will also have you meet with HR, where they'll answer some of the more practical questions. So leave, salary, expectations, some of the more technical aspects, some questions that you may have and haven't had an opportunity to ask yet. Some places may actually also have fun add-ons. They might take you like on a night tour of the city. They might have a real estate agent drive you around and see different properties in the area, so you get a feel of, if I move here, if you're coming from out of state, where might I live and what might I do? So every interview session's a little bit different, but typically they're 2 days in length. So after you've completed your interviews, you're going to want to take a deep breath. They're lengthy, as I mentioned. It's a lot of information. You met with a lot of people, and it's a big decision. So allow yourself some time to decompress and just kind of breathe, and then go back to your notes, go back to your checklist, go back to the questions you asked, and then start to really process that experience with that institution. Thank you emails are still welcome. So in prior days, many of us did, like actual thank you cards, but thank you emails, especially if you had a really good connection with someone and want to mention and help them remember your interaction by mentioning something that you guys talked about, are very helpful. And it's also an opportunity to ask any follow-up questions. So most people will say, please reach out if you have any questions. Absolutely do so. Absolutely do so. Once you're finished an interview with an institution, you'll usually get an email within about a month that'll contain one of the following. They may give you an offer letter. So this is a document that has kind of the basics of your duty, salary, time off. It's not a formal contract, but it is a document that's saying we are interested in hiring you. And by signing that, you're committing to continuing in that process. So that offer letter is a really big step in the job application process. It's also a time to have further conversations. So maybe they aren't offering you a letter at that time, but maybe they have follow-up questions for you based on your conversations during the interview, or they may have specific questions about how to best craft your offer letter based on what they find that you need, what you can contribute, and how they envision you fitting in with their group. Or they may notify you that it was a pleasure to meet you. However, they're not going to continue in the interview process and the intake process at that time. When you get any of these communications, you want to respond in a timely manner within about 2 days to thank them for the opportunity and respond to their questions. So they may, if they give you an offer, they may give you a time frame in which they want to hear a response. But if not, it'd be optimal to give them an expectation of when you're going to be able to respond. Because even if you feel strongly, you still want to take time to think about it and review that document. Because again, this for most of us is the first time we've had to do so. So what's the difference between an offer letter and an employee agreement, aka a contract? So in both cases, you want to reply promptly when you receive it and give them notification of when they can expect a response. Because again, depending on when you interview and how they're lined up in the year, you may interview somewhere, hear back from them before you even finish your other interview. So you want to be conscientious, you want to be transparent while also protecting your privacy that you're allowed while you're still navigating through that time. You always want to let them know if you have questions and outline them carefully when you get either document. And the tone of your response should, for both, reflect your true feelings. So if you really don't think that a place is a match for you, despite back and forth, I would avoid being overzealous and over positive if that's really not how you truly feel. So again, yes?
I am so sorry to interrupt. I think we are out of time.
Okay.
Would you be able to send a little bit of this to our audience today later?
Sure.
Thank you. I truly appreciate all the tips you provided, and I think this session should be an hour, 2 hours. It's an important one. Thank you so much. I think it's time now to join the main group with Dr. Bindal. We will be transitioning to the final session of today's program. I'm happy to introduce Dr. Bindal to present on networking, importance, and implementation. Dr. Anila Bindal currently practices general endocrinology at Northwestern in Chicago, Illinois. She completed her residency and fellowship training in diabetes, endocrinology, and metabolism at University of Chicago Medical Center in 2016. She's a member of ADA's Focus on Fellow Advisory Committee and has interest in helping trainees develop leadership skill. She's a chair of Women's Faculty Organization and at Northwestern, and a steering committee member of Northwestern Women in Medicine Group, both of which are dedicated to empowering and advancing women in medicine. Welcome, Dr. Bindal. I'd like you to take over now.
Yeah, absolutely. So that slide I think said Rush, but actually I'm at Northwestern now. And hi Bhargavi. I'm really excited to be here with all of you guys. And I'm really hoping we can make this a little bit more interactive because it's really for all of you guys. So please do ask questions. Anything that comes up that has to do with networking, please do type it into your chat so that, or even unmute yourself and ask so we can help answer your questions today. So I guess I can just go ahead and get started unless there were specific questions that you had, Bhargavi, that you wanted me to focus on.
Okay, so let's, I do have a few questions. The biggest one in my mind is, how has networking impacted you in your career?
Yeah, so networking is, I think, one of actually the most useful skills I think any one of us can actually have. And if you had told me maybe when I was like 5 years old or 12 years old or even 20 years old that I would ever want to do any kind of public speaking, or networking, I would have told you you were absolutely crazy, because I was the shyest child you will ever meet and absolutely hated anything that had to do with public speaking or meeting new people and making small talk or anything of that sort. And it's something that I really had to develop over the years. And it's very interesting because the more I've learned about networking, the more I can see how absolutely imperative it is. You know, we all accept these stories about celebrities who end up getting the big break after meeting just one person, but we don't realize that this is a thing that actually happens in our own lives and that it can happen really for all of us, essentially. When you're someone that someone else knows and they feel like is trustworthy and they endorse you in any kind of opportunity you're looking for, your name goes to the top of the pile. And actually, the Harvard Business Review actually says that 85% of jobs are found through networking. 70 to 80% of jobs actually are never listed. So 85%, can you believe that, are found through networking? And there's this book called The Strength of Weak Ties by this author named Mark Granovetter. And he actually says you're 58% more likely to get a job through an acquaintance than you are through somebody that you know really well as well. So when we talk about networking, you know, we don't necessarily have to create this very tight, these really close relationships necessarily with people. And in fact, actually, some of the best type of networking you can do is really cast a really wide net, but try to meet with people who you normally wouldn't necessarily talk to, who may actually be outside of your field or specialty. And that's actually gonna give you the most success. So they actually think that having a large structure with actually relatively weak connections is far more important. Now, I know that seems a little weird. Why would that be? And it's because we actually want to try to have access to people who have different knowledge than the people you already know. So even in my own life, so, you know, I told you I now work at Northwestern, and I used to work at Rush. And so that's why they had Rush that was under my name there. But even my job at Northwestern, I actually got through networking, and I didn't realize it at the time. But it was actually a person, a friend of mine now, who we knew each other 20 years ago, or rather my parents knew his parents. I did driver's ed with his brother, had heard about his name, hadn't met him. And then I finally did meet him a few years ago because he ended up getting married to a friend of mine who I was in residency with. And then, so it was a very, you know, distant type of a connection. But then he actually referred me for this job. He's a primary care physician there. And now we've become friends. Sometimes I think when we do networking, we think that we should be able to go to an event, talk to someone, and then like 20 minutes later, we should be able to have, you know, the job laid out for us. You never know when that sort of return on investment is going to be. All this work you do to go out there and make small talk and get to know a bunch of people. Sometimes it might even pay off 20 years later. Sometimes it can pay off at the very next time that you're looking for something. So it really can have effects that you never realize might actually end up coming in handy for you one day. So yeah, it really is important.
Thank you so much. I think you have brought some very unique perspectives to it, including the fact that you had to outgrow your inherent limitations in order to network. So how do you suggest, I mean, our fellows do that? There is an initial level of hesitation, I see, for them to reach out. How do you break that barrier?
Yeah, I'm so glad you asked, actually, because this is something that I think is a really important topic as well. And I'm going to change the word inherent limitation to actually a perceived limitation. Everyone here is very successful. Everyone here is social. They know how to speak. But I think sometimes it's our own brain that makes us believe that we're not good at things that actually you might be, you know, better at than you realize. So what I would say is the big things to start to focus on initially, one of them is going to be keep doing it. It is something just like anything else where practice makes perfect. The more you do it, the more it will become more and more comfortable. The beginning will feel weird. I think it's partly because small talk, a lot of people don't necessarily like small talk either. I'm still not a huge fan, but you do have to do it during networking. One thing I would say is just get good at small talk. And when I say that, that doesn't necessarily mean that you have to be more interesting and you have to come up with things to say for people. One of the most common things that people talk about when they say, oh, I'm not good at networking, is that they say I'm very much of an introvert, or they tend to assume that they're very quiet and they don't have much to necessarily add, or they feel like they're going to say the wrong thing. Well, one thing that's actually, being an introvert is actually potentially a huge asset to networking. And the reason for that is one of the best things you can do is listen. The people who you oftentimes do want to network with, they might actually just want to talk about themselves. People love to speak about themselves. And if you actually give them a platform to do that by just asking them questions and being good listeners, that's more than 50%. That's probably 75% of networking. And so, so people who often feel like they don't have anything to contribute, they can just start by asking a question. Just come up with a few questions even for small talk, and then go from there. And then you can kind of learn over time how to respond in such a way so that you're also able to talk about yourself. If you're having trouble trying to come up with questions, do your homework ahead of time. If you know what the venue is going to be, think about the city, think about what they're serving, think about what your greater goal is. So one thing that happens a lot is we go to networking events and we think, well, we feel very uncomfortable with taking something from someone, or, you know, I'm going to bother them, or they're going to be annoyed by me, or something like that. But if you really see networking as more of an exchange, then you really show up not feeling like you're taking something, or that you're bothering someone, but you're always constantly looking at how can I contribute? Who is here that I can actually help in some way? Maybe there's someone you can connect with the person who's there. Maybe you're speaking with an endocrinologist and they're telling you they really enjoy, you know, X, Y, and Z research, and you happen to be working with an attending who's exactly a huge expert in that, now you can offer and say, hey, you know, Dr. So-and-so at my institution actually is really passionate about this. Do you think I can connect you guys if that would be interesting for you? And so thinking about how you can potentially give something back is something that can be helpful. And then I think if all else fails, just always thinking about your greater goal. You know, most of us, even when we're thinking about jobs, you're not just looking for a job. You're looking for how can you help people with diabetes? How can you help manage technology more efficiently? So what's the greater good that you're trying to bring to the table? And that focus doesn't feel as scary as, you know, what can you do to help me personally?
Truly a lovely perspective. My question is, does networking, I mean, when we start thinking about creating collaborations, right? The thought process is reach out to somebody who is higher and senior in stature than you. But what do you think about collaborating with peers, you know, other fellows, for example, or, you know, those who have just started their faculty position? What are the merits for the peer-to-peer collaboration?
Oh, 100%. And again, this is something I'm really glad you asked, because there were some points I wanted to highlight here too. I would say network with as many people as you can at all different levels. There's a lot of studies that talk about how women network differently than men, and we can talk about that a little bit more as well. But one of the things is that in general, women are far more likely to network with people who are sort of at a lower level, like rank-wise, than they are. Because again, they're always thinking about how can I help someone else rather than necessarily thinking about how can I get something. Men are far more likely to be okay with networking with people who are their equals or potentially at a higher rank, because they're okay. This is a complete overgeneralization, of course, but they feel like it's okay for them to receive and then pay it forward to someone else, even if it's not an even exchange with that same person. But you know, you want to be looking, when you're mentoring, you want to be looking for allyship, you want to be looking for mentorship, you want to be looking for sponsorship. And what is the difference between those? So allies are the people who are going to be there on a bad day, perhaps say, I totally hear you. Yeah, fellowship is hard. It sucks when you have to get up at 3 a.m. to, you know, return a page. So you want to look for the people who are going to be true collaborators that are other fellows as well. You also want to look for mentorship, which is going to be the people who are sort of pushing you a little bit more to get out of your comfort zone, who are trying to get you to do the things when they really see the potential in you. And you want to seek out sponsorship. And sponsorship is going to be focused on the people who can actually create opportunity for you, for the people who are going to say, hey, here is a talk that I really need someone to give. And when you tell them about yourselves, you might actually find that that person says, I have a talk coming up for this. Do you think you would be interested? You know, there's a paper that I'm looking to write. I think you might be a good person for that. So it's actually creating opportunity. I think all of those are important. And in fact, there's, again, literature looking at the kind of networking that happens. So a lot of people are networking for jobs. People in managerial positions might be looking to try to move up or gain more skills. And then people who are even at the top rank, so to speak, they're looking for collaborating on ideas. So networking never stops, but you might think about what you really want going in out of the networking and then hone your audience accordingly as well.
And the value of networking for personal gain, you know, how does that come into play?
Well, so I see all, oh, sorry, go ahead.
Just if they're not like doing exactly the same things professionally, but some other way you connect, what are the benefits of creating networks like that?
I think one of the nice things about networking is you never know how somebody that you're talking to and meeting with, how they might play a role in your life, right? So actually one of the ways that I even learned about the advisory committee here in Focus on Fellows was because I spoke with Meltem. Meltem told me about this many years ago when we were still in fellowship. And, you know, now here I am several years later, and now I'm having the opportunity to sort of give back in a different way. I think that there's people that I've networked with where it initially started out with being more of a, I just want to get their advice on this or something very specific to endocrine. And then eventually I learned even personal gains we talked about. So actually a really good person who's an example of that is Rochelle Naylor, who is one of my mentors from University of Chicago. And we started out working on projects together when I was a fellow and she's an attending, but we've actually transitioned into more of a collaborative mode where I actually will give her ideas or suggestions for things, and she'll give me ideas and suggestions for leadership and women. So I do think that can be across the board, and it can play a huge role in your own personal development. And, you know, networking, I think the thing that makes people the absolute best at networking is just constantly focused on personal development. The more you work on that, the person you show up to be is going to be exactly the person that other people want to talk to as well.
No, we all connect during national meetings, right? I mean, we hit it off great. And maybe we will exchange emails, phone numbers, maybe even text each other for a bit. And then it fizzles out once we go back to our lives. How do you nurture these contacts you have developed during these meetings?
Yes, absolutely. So I'd say the two biggest things, if there was nothing else, well, I guess three things that I would say as a takeaways for these would be making sure you try to have a large network that is actually quite diverse. The second one is going to be, you know, just getting out there. And the third one is actually exactly what you're saying in terms of maintaining the contact. So this is probably the one that becomes the hardest to do for people who are so busy, like all of you guys are here. But this is also probably the most important. So what I would recommend, there's actually, if I'm able to possibly share my screen here for a second, there's one quick little slide that I would. Okay, great, thank you. So there's one quick little slide that I'll show you guys here. So there's this, it's a follow-up. It's called the Misner's 24/730. And what he recommends is within 24 hours, send the person either an email or a card. Within 7 days, try to connect with them on whatever platform the person prefers. So if they gave you a business card and they said that they like to connect on, you know, Instagram or LinkedIn, use that specific one because it's showing that you're willing to make an effort. And then within 30 days, reach out to the person and said either a time for some kind of face-to-face or virtual way of reconnecting. That's a good amount of time as well for someone to kind of remember you, but not make it feel like you're necessarily, you know, running into them or using up time constantly, but it really helps them remember. If you do that and now you've had 4 contacts at that point, you know, you met them the first time, 24 hours, 7 days, 30 days, the person is going to remember you, and reiterating what it is that are your main points that you're hoping to potentially, you know, do in life, I think will really help to keep that person, you know, remembering. One thing you want to do also, though, is if you say you're going to do something, if you tell the person you're going to email them, if you say you're going to connect them with someone, keep your promises. People will sometimes remember that. So you do want to follow through on anything that you say. And then I think in terms of just networking in general, sometimes it feels like a pain for people and they're like, I don't really have the time for this. I would say give yourself even 10 to 15 minutes every week, 10 to 15 minutes every other week at least. That way you can think back and say, okay, these 20 minutes or 15 minutes is just dedicated to looking at those networks I'm trying to build again. Who have I not heard from? Who have I forgotten to email? And just setting 20 minutes, I'd say about 20 minutes or so every week to every 2 weeks can really help with making sure that you're doing this consistently as well. Oh, I think you're on mute, Bhargavi.
Yeah. I'm going to pick on one of the statements you made earlier. I want to delve deeper. You said women network differently than men. Can you explain it a little bit?
Absolutely, yeah. So I think this is one of my favorite topics because I think it's so interesting how there's a lot of literature about this, but how we're not even necessarily aware of these minor differences. So first of all, women in general tend to undervalue their own worth when it comes to professional activities. They tend to typically sell themselves short. They do also tend to network down, like we were talking about. They typically, when they're networking, look for people who they like as people or who they want to be friends with. They also oftentimes will end up connecting more with people for emotional support rather than necessarily opportunity creation. We don't have to like our mentors. We don't necessarily have to like our sponsors. Men in general tend to feel, the literature suggests anyways, that men in general are okay with continuing to connect with men or with other people, even if they don't like them. because they know that what they're trying to get out of it is potentially some kind of an opportunity creation. Women also tend to, in general, feel like that when they're connecting with another somebody that they're networking with, that they have to have an equal exchange with that person. So they feel really bad if they don't think that there's something they can give back to that person. Whereas men often know they can pay it forward to someone else. They don't feel bad sort of using their network, which is what women are often concerned about. That's how they see it. The other thing is too, that women in general are more likely to network with other women. As it stands right now, in general, older white men still hold the most power. So I strongly encourage all men and women to really try to focus on still networking with men also, even if they feel uncomfortable or they feel like, again, maybe they feel like they don't have anything to offer. And then I'd say the other thing too is that women in general try to form closer relationships with the people they're networking with. Men kind of know that this tends to be more of a, unfortunately, I hate it saying it this way, maybe because I'm a woman, but they think of it as a transactional relationship, and they're okay with the relationships dissolving after they end up getting what they need, with the caveat, again, that they know that they are going to be able to help someone else in the future. So they don't feel like it has to be one-to-one so much. The other thing too, in terms of networking, when there are more women's networking activities, they in general tend to be shorter, maybe a lunch or something like that. For men, it'll be very long ones. They'll go out on a golf outing where they really get to connect and get to know each other. So there are quite a few differences. Now, there's also some literature. In fact, there's even some that came out of Northwestern's Business School, Kellogg, about should women be networking differently? And what they really found was, as long as they're still forming a very diverse network where they're trying to get to know people who are not necessarily in the same circle that they would think. So, for example, I would encourage you all to not only network with endocrinologists. You want to network with a wide cast of people. Some people who are not in medicine, some people who are not in, within endocrine or internal medicine. You never know how that's potentially going to help you. They find that wide, that cast of networks that's really wide actually does still tend to help. And then the only other point I'm going to bring up about this is, in general, when women were still promoting other women, that actually tends to help a lot in networking as well. So that also has actually helped to reverse or reduce some of these things that the literature suggests about how women and men network differently.
Wow, that was eye-opening, but so true when you think about it. Now, what are the biggest fallacies of networking?
Yeah, so I would say the biggest fallacies really are the ideas of what we tell ourselves. Am I loud enough? Should I be more interesting? I'm too shy to be able to speak up. And that's where, again, some of those things I really want to highlight are going to be some of those things I mentioned with not necessarily feeling like you have to be so interesting. You can also be just focused on being interested. So as long as you're able to ask questions, it's okay to exit a conversation if you feel like you want to move on to talk with someone else. Sometimes I think people are concerned about getting stuck with someone. So it's okay to do it, just do it gracefully. If someone is saying something that makes you feel uncomfortable, one thing I recommend is just making sure you take a deep breath and focus on being responsive and not reactive. If you feel like you don't know what else to talk about, just talk about the stuff right in front of you. If you're drinking a glass of wine, talk about that. The other thing that is actually also can be helpful is strategically where you place yourself when you're trying to network. So you don't want to be standing near the bathroom, and you don't want to be standing near the entrance. One of the best places to stand is actually right after someone grabs a drink. Usually what people will do is they'll come in, they'll put their coat and stuff down, they'll go and grab a drink, and now they're ready to network. And if they happen to see that you're the first person there, or you happen to be strategically placing yourself there, you'll be able to make more conversation with more people. And if you happen to be one of the earlier people they talk to, maybe they'll go ahead and move on, and you can know who you want to talk with again later if indicated.
Can you give us some examples of national networking events for the physicians and specifically for our endocrinologists here?
Absolutely. So I think there's so many different types, again, depending on what it is that you're trying to achieve. So definitely the WIN ADA, which is the Women's Interprofessional Network through the American Diabetes Association. I think Focus on Fellows is a really great place to network, especially when we were doing this in person. I know a lot of times we would have the ability to have a small networking reception afterwards as well. ACE is a good one. Endocrine University is a great one. ADA. Now, again, I really want to hit home the idea, though, that you don't want to limit yourself to just endocrinologists. And you don't necessarily want to limit yourself to people within just internal medicine, just within medicine. This is something I learned for myself just in the last couple of years. I have learned that sometimes some of the best leadership advice I've gotten, some of the best ideas about how to think about how I can be a better physician, things of that sort have actually come out from people who are not doctors. I've learned a lot of leadership advice from people in business, from people who are in the pharma industry, pharma dinners, whether people choose to go there or not, but those are places to network. Any kind of associations. I mean, really, you can network almost absolutely anywhere. That's the part that's really good, is that every opportunity you have to meet someone else is technically a networking opportunity. And if you treat it as such, without even necessarily thinking about it, then when there is something like a big ADA event where there's all these big names and things of that sort, it won't feel so intimidating because you've already been practicing this in your own life and at a picnic or at a barbecue or, smaller events as well.
We have 2 minutes left. I want you to kind of summarize it for us. What is the take-home message you'd like to give our audience today?
Absolutely. So I would say, number one, just get out there and do it. You might fall on your face a couple of times. You might have, something on your face that you didn't realize, or spinach stuck in your teeth, and that's okay. If people will move on from it, it'll be completely fine. The number two one I would say is try to cast as wide a network as possible. Number three, follow up. Try to remember who you had spoken with and just see if you can reach out to them in some form. If it's someone you particularly want to connect with, then make it more intentional. I would say the number four thing is, if there are concerns, a little bit of positive self-talk will be really helpful. Develop a strategy ahead of time. Have your elevator pitch ready where you introduce yourself, say what you're doing, say what you're looking for and why. And I think if you do those and just keep sort of rinsing and repeating, you'll find that this really can benefit you in far more ways than even just looking for a job or simply just getting to know people. I mean, personally, professionally, in every realm of life, you'll be a better person from networking.